Hi guys, so welcome to I think it's part 4. Yes, part 4 of arterial blood gas interpretation. So maybe you wonder, why am I doing so many sort of like sections on this? It's because it's very important, and I know it's one of those things that they are so important, and it's also very difficult to wrap your finger around. So that's why I'm making sure that I'm spending a lot of time on it, just to make sure that each and every one of us, after we're done with this series, we can interpret an ABG with confidence. So what I want us to talk about today is compensation. By the way, I still have got flu, guys. I'm fortunate that I'm on leave. So I'm not at work. So let's talk about compensation. What is compensation when it comes to acid-base imbalances? A compensation is, or these are mechanisms that the body employs or activates to try and bring the pH to normal again. So if you've got so they can come in the form of chemical, they can be respiratory. So these mechanisms can be respiratory, or they can be renal. Remember, homeostasis. So we want homeostasis in each and everything. So we don't operate on the extremes. We want everything to be nicely in the middle. So when it comes to chemical, the body uses bicarbs as a compensation, phosphates and proteins. Renal, it uses protons, bicarbs. These are bicarbs, né? Or protons. Remember, when you've got a lot of protons, you are creating, or you have created, an acidic environment. When you've got a lot of bicarbs, you have created an alkaline environment. Respiratory is just a matter of playing around with the partial pressure of CO2 here, decreasing it or increasing it by either hypoventilating or hyperventilating. There isn't much there. So you just play around with the partial pressures of CO2 by either hyperventilating or hypoventilating, depending what kind of an imbalance do you have, or what kind of an abnormality do you have, which we're gonna speak about. So I don't want to I know maybe you're looking at me and asking yourself, why am I saying bicarbs here and I also put bicarbs there? Remember, bicarbs is a chemical. It's an chemical, but the renal uses chemicals to correct the thinking. So what I wanted to make sure that I wanted to put this as well, so that you can know where things fit. As much as I won't speak much about the proteins and the phosphates, but you just need to know where it fits in case they ask you in an exam, or they want you to list other ways. Okay, so now that we've got that out of the way, when you talk about compensation, when you've got a renal problem or a renal acid-base imbalance, you expect your respiratory to be the one that is compensating. Vice versa is also true, or the opposite is also true. Vice versa is also true. So the opposite is also true. When you've got a primary respiratory problem, you expect your renal to be the one that kicks in and try to compensate. Okay, let's do examples so that you can understand it. By this time, I expect each and every one of us to be able to look at an ABG and say, this is a respiratory problem. This is a respiratory alkalosis, or this is a respiratory acidosis. This is a metabolic acidosis. This is a metabolic alkalosis. Because this one is at an advanced level than that, because it's about compensation. So before watching this, I would encourage you to go back to the other videos and just make sure that you understand everything there and then come here. Okay, so let's say you have a respiratory acidosis. Let's say that's what you have diagnosed by looking at your strip. When you say you've got a respiratory acidosis, if you are calling me on the phone and saying, T, I've got a respiratory acidosis, in my mind, I will know that you are saying you've got a patient that's got a pH that is less than 7.35. Number one. Number two, you are saying that the partial pressure of this patient is high, meaning more than 45. That's what you are saying to me. Now, when you say that, you expect the renal to be the one doing the work to bring this abnormal pH of this patient back to normal. What will the renal do? Remember, the renal has got an ability to either retain protons or to excrete protons. Number one. It also has an ability to either retain bicarbs or to excrete bicarbs, right? Depending what's happening. So for this patient that you're telling me about that has got the respiratory acidosis, which compensation do we expect? So when you've got acidosis, it means you've got a lot of protons already in the blood. Already. So it means you've got a higher concentration or a high concentration of protons already in your blood. So retaining this guy is not going to make sense, because if you retain this or you keep them in the body, you will be adding protons to the protons that are already increased. So in this case, you must get rid of this. So it means you must excrete the protons. And we know that when you excrete protons, you will decrease these protons that are in the blood. That's the one way you will decrease you will correct your reduced pH, which is acidic. While the kidneys is doing that, the kidneys will also retain bicarbs, because your bicarbs, as much as you are getting rid of the protons, you want something now that will also increase the pH to normal, because it's slow. So retaining protons, we said that retaining bicarbs will give you a high concentration of bicarbs, and that will push your pH up and take it out of acidity to normal. So what I'm saying here, when you've got a respiratory acidosis, you need to retain bicarbs in the body. and you need to excrete your protons. That's the renal compensation that you expect from a respiratory acidosis. Okay, let's move right along. Now let's talk about respiratory alkalosis. So when you call your friend and say, Doc, I've got a respiratory alkalosis, you are saying to them that, Doc, I've got a pH that is greater than 7.45 and I've got a partial pressure of CO2 that is less than 35. Remember, blowing out CO2 gives you alkalosis, but retaining CO2 gives you acidosis. Remember that. So what sort of mechanism, what kind of compensation do we expect here? So your renal will come in, will do the opposite now. So instead of now excreting the protons, the kidney will now retain the protons, because we know that we've got a high pH already. So to drop the pH, let's bring in more protons to try and neutralize that alkalinity. So we will retain sorry. So we will retain the protons and excrete the bicarbs, because we know that once you keep a lot of bicarbs, you will worsen the alkalosis, because keeping a lot of bicarbs, retaining a lot of bicarbs pushes the pH up further, and we already have that kind of a problem. Okay, now let's talk about I want to make sure that I use all these markers. So now let's talk about metabolic. So let's say now you've got a metabolic acidosis. By definition, you are saying you have a pH that is less than 7.35. That's acidosis. But what is telling us that it's a metabolic is the bicarbs. So you've got bicarbs that are reduced less than, some say 21, some say 22, so but less than that. So that's what you have. So when you've got that kind of a situation, the compensation that you expect from them, because now the problem now is metabolic here, so the compensation that we expect should be a respiratory compensation. So the lungs must come in and help us out. So you've got acidosis. We know that if you've got metabolic acidosis, if you retain CO2, you will become more acidotic. So the best thing is to blow out CO2 or hyperventilate. So when you hyperventilate, you will blow out a lot of CO2 and correct this problem. That's the first thing that's going to happen. So this patient will be sort of like panting when you see them. They'll be like, they'll be panting. So because they'll be hyperventilating, because the body knows that if they start to hyperventilate, they will retain more CO2. And when they retain more CO2, when they retain more CO2, they will become more acidotic. And that's not what you want. That's not what you want. Let's talk about metabolic alkalosis. I'm sure by now everyone understands what's happening. So you've got a metabolic alkalosis. By definition, it's a pH that is more than 7.45, and we've got what's happening with our bicarbs. Our bicarbs are increased in this case. So the kidneys have been retaining a lot of bicarbs. So what the lungs will do in this case, will try and retain CO2. So CO2 will be retained. Because we know once you retain CO2, you increase acidity, and that's what you want to do to counter the alkalinity that is this side. So this patient will hyperventilate. Don't have that deep, slow, labored respirations. So that's compensation. So I want now us to talk about these three terms. I hope everyone gets this. Let's talk now about these three terms. When do we say now this is compensated, this is partially compensated, this is uncompensated? I know there are people who don't like, who just stick to compensated or who sticks to partially compensated or to complete. It's just people choose to use words the way they want to use words, because there are people who disagree that there's nothing called uncompensated. But let's do this. So there's no compensation, and then there's partial compensation, and then there's complete compensation. So now this is a way of saying what we've just explained now, has it worked? Are we getting what we expect? Because we said when for metabolic acidosis, for instance, we expect the renal to cause alkalinity. So are we having that now? That's what we want to check now. So to check that, this is what you must keep. So you look at the pH, right? We said a pH that is less than 7.35, it's acidity, and a pH that is more than 7.45 is alkalinity. And then there's a middle number here, 7.40. So when you have a compensated acid-base disorder, you will have this area. So your pH will be somewhere here. It will be somewhere here, but more towards the 7.45. More towards the 7.5, like 7.44, 7.43, 7.42, somewhere there. So it will be so what I'm saying to say, this is, I'm talking about alkalinity now. Okay, let's say we have alkalinity, né? We've got alkalinity or alkalosis. So that's what we are having. So let's say that's what we are having. So when you look at the pH, for someone who's compensated, first of all, they have a normal pH. The pH is normal. That's someone who's compensated. Their pH is normal. But as much as it's normal, it's towards this end. It's towards this direction. Right? It's not in the middle. It's toward that direction. Suppose that there's nothing wrong with, you say there's nothing wrong with that. But when you look at your partial pressure of CO2 and your partial pressure of bicarb, that's where you will pick up this patient had a problem, actually. So depending what was the initial insight that you had, you can have, so we're talking about alkalinity. Let's say, okay, we're talking about alkalinity, né? So we're saying for someone who's fully compensated is someone who has a normal pH, but their normal is towards the alkaline side, even though it's not more than 7.45. It's not above 7.45. It's towards. It can even be 7.45 for that matter. But it's towards that number. So that's someone, you will look at the patient and say, this patient didn't have a problem. But wait up until you look at these two. So these two will be abnormal. These ones will be abnormal. And then you'll be like, oh, okay. For the pH to be closer to the alkaline side, even though it's normal, for it to be closer than the alkaline side, it means we have a problem. We had a problem. So we had a problem, and these two guys are correcting the problem, depending which one is compensating for what, depending what happened. Yeah? So you will see that these ones will still be abnormal. They are remember, normal partial pressure is 35 to 45. This one is 21 to 27. So you will pick up that this guy, it's either it's very high or it's low, or this guy is high or it's very low, depending what insult you had. But what I want you to get is that for someone who's compensated, is someone who's got a normal pH, but the pH is towards the alkaline side. We're talking about alkalinity now. And then you've got abnormal values here. Let's come this side. So also the same thing applies here. You have a pH that is closer here. So the pH is like 7.35, 7.36, 7.37, around there. That's a normal pH, right? That's a normal pH. But what will tell you that this pH has been compensated, it's the abnormal partial pressures of CO2 or CO3. That's what's gonna, because those ones will be abnormal. So that's someone who's compensated. And then now you can try and study and see, okay, what was the initial insult? And also the clinical presentation of a patient will tell you what was the initial insult. Let's talk about partial compensation. With partial compensation, one thing that you must remember is that here you still have got an abnormal pH. The pH is the pH is normal, but towards the extreme ends, be it acidosis or alkalosis. And then another thing that you also have here, so pH is normal, but you've got abnormal CO2 or COO3. For partial compensation, you have an abnormal pH, number one. You have an abnormal pH, and you also have abnormal CO2 or COO3. That's a partial so it's partial in the sense that these guys are trying to correct the problem, which we appreciate, but they have not brought the pH to the normal. The difference between this and this is that these guys, as much as they are abnormal, they are abnormal, but they've managed to push the pH to normal, even though it's still towards the extreme ends, but they've managed to do it. But here, these guys are abnormal. They are still trying to correct the problem. But it's just that they have not brought the pH to normal. That's a partial compensation. Let's talk about uncompensated or no compensation. Here, you've got an abnormal pH, and these guys are normal. Normal CO2 and normal bicarbs. So basically, this means that you have got an abnormal pH, but these two guys have not done anything about it. So that's how you figure it out with what's happening. So I hope you enjoyed that, guys. I think the last video I will do is gonna be mixed disorders, which is more troublesome than this. I hope you enjoyed this. Thank you so much. Please guys, I need you to like, I need you to share, I need you to subscribe, please, guys. Like I always say, the success of the channel is not really about the content. It's about you guys liking. It's about you guys commenting. It's about you guys sharing. And I need you to help me out on this. It also motivates me a lot. Thank you so much.